Peter Block here at TCT 2015, and with me is Stefan Desch from Germany. Stefan has been working on late aspiration in ST elevation myocardial infarction. So, Stefan, tell me about your study. How did you put the study together, and exactly what was it to begin with?
It's a randomized study of 152 patients, STEMI patients. We did a trial of manual thrombus aspiration versus conventional PCI in subacute STEMI. That is between 12 and 48 hours after symptom onset. So all of the previous trials before have been done in the early setting within 12 hours. So this is the new and only study thereafter.
Okay, so you did it late. Did you randomize to yes aspiration, no aspiration, or how did you figure it out?
Yeah, yes and no.
Okay, so the control did not have anything further. Most of the early aspiration trials we're learning even from this meeting have been sort of a disappointment. They have not shown an awful lot of difference, if any, and now we have a late aspiration. So I guess the next question is, what'd you find?
Well, I have to disappoint the audience as well. Yeah, the primary endpoint was microvascular obstruction on cardiac MRI, and we didn't find any significant difference in this primary endpoint between groups.
You didn't measure infarct size or anything like that?
Oh, we did, but just the secondary endpoints. There were no differences in MRI infarct size, enzymatic infarct size, other MRI markers such as left ventricular ejection fraction, volumes, myocardial salvage, angiographic markers of reperfusion success, such like the TIMI flow post-PCI or the blush grade. No differences at all.
Wow, that's a lot of endpoints. Okay, so let's have a little conversation about this, because one of the important questions that everybody is trying to figure out is, should I just throw away this whole business of aspiration and not even consider it? What are your thoughts on that?
Well, you shouldn't. You should keep it in the shelf, because all of the trials we are talking about, including ours, are routine upfront manual thrombus aspiration. And it is still a viable option in the selected patient, occasional patients, as a bailout therapy. So I would suggest you keep it in the shelf, but try to limit it to selected cases.
So a selected case, let me give you an example of one that I think might be reasonable. You try to open it either early or late. You are faced with a lot of thrombus burden, put a balloon in, nothing happens, the vessel looks terrible and full of garbage. Would you at that point say this is probably worthwhile, even though the endpoints may not change?
This is a tough question. I personally would probably do it, but you have to be aware that since the total trial is out, we also have a signal of increased stroke rate in these patients. So this is really a balance, a clinical decision. Yeah.
Okay, so we haven't thrown thrombus aspiration away, have we, Stefan? But on balance, it's not probably going to be something we turn to immediately for every ST elevation myocardial infarction, but every once in a while it might, with good judgment, make sense.
Yeah, exactly.
Thank you, Stefan.